But talks about approval, believe it or not, we were living our life with one drug, sorafenib. Out of nothing, we're talking about two in the first line with an expectation for one of them, lenvatinib, to get an FDA approval soon. But already we have two drugs approved in the second line, like something totally new to us. So tell us a little bit about regorafenib.
Yeah, so regorafenib has also been tested in a large phase 3 clinical trial, and the trial was also positive. So regorafenib is very similar to sorafenib, but the spectrum of kinase inhibition is different, and therefore, I mean, there was clearly a rationale to test regorafenib after sorafenib failure. And I mean, we had a lot of discussion on tolerability of regorafenib in other cancers. So I think it was a wise decision to focus here in HCC on patients that do tolerate TKIs and specifically sorafenib. So this trial was designed to test whether regorafenib is better than placebo in second-line treatment for patients that have received sorafenib, that have tolerated sorafenib, and that have progressed on sorafenib. And in this predefined group of patients, there was a significant overall survival benefit, which was very similar to the survival benefit we have seen for sorafenib in first line, 7.8 months to 10.6 months. So there's a 2.8 months improvement in median overall survival, and I think this is clearly an indication of a efficacious drug, and with that, I mean, it was improved, I think, worldwide for second-line treatment in this group of patients.
No question. It's something fascinating, and we thought first it's really very close cousin, no more than that in regard to sorafenib, but now we know that there are certain variables. We only have biologic concepts. We don't have them proven, but for example, IGF and IDH more probably could be over-exaggerated in regard to expression after a progression on sorafenib, and as such, having the regorafenib, which has high IC50s in regard to those, might very well be a good impactful therapy in that regard. And I think, interestingly, add to the data that you just showed, Arndt, in regard to the regorafenib versus placebo, my understanding, even though it was not planned study, but the cumulative survival for sorafenib followed by rego, 26 months.
Yeah. So, and I think this is also very impressive, and therefore I mentioned the numbers before for the local therapies, TACE, median overall survival, 20 months. I mean, patients that have an earlier disease, yes, more stage B patients. So, and I think we need to start to do this cross-trial comparison. And again, this is retrospective analysis, selected group of patients, I mean, patients that were candidates for clinical trials in first and second line. So, I mean, we have to be careful, but still, if you look at the combination, 26 months, I mean, this is the new benchmark we can achieve with systemic therapies. And this is also true for the second drug you mentioned. And I have to remind you that this is a global program, and we have only one in Germany, at least, only one approved drug in second line. Nivo is not yet approved in Germany. But I think for the immunotherapy, we have also very impressive data in second line. I mean, first line, it's even more impressive, 28 months for Nivo. Again, no control arm, so we need to be careful, and we have to wait for the phase 3 data. But I think what we have so far in second line, 15 months for Nivo and 13 months something for pembrolizumab, I mean, there's a clear indication that immunotherapy works in second line HCC.
Well, thanks for the reminder, but at the same time, you bring me to a very important point. So we're going to break from the checkpoint inhibitor, from the TKIs. We'll come back to them in a second, but let's talk about checkpoint inhibitors.
Yeah, I mean, I think the FDA made a fairly aggressive move, but it's not unique to liver cancer. I think we've seen with other diseases with checkpoint inhibitors that they are making aggressive approvals based on smaller studies or single-arm studies. And you could argue whether or not it was the right decision, and we'll know that when we see randomized data. But needless to say, it's a great thing for patients because they get an option, right? I think we're convinced that these drugs are relatively safe in this population, and there are certainly patients that do really well, right? And the approval label is a response rate of about 15% with a duration of response of like 16 months. So if you respond to one of these drugs, your response is probably going to be fairly durable. The holy grail is, who are these patients, right? And as far as we know, PD-1 expression, PD-L1 expression hasn't correlated with this. This is an area of great interest as far as biomarker work. I think in the context, and this approval came after we had seen the results of the resource study, after its approval in early 2017. And this sequence of sorafenib to rego, 26 months, is a very provocative number, right? And I think the challenge for us as we get new drugs approved is what is our choice for second line, right? Well, I'm sure we'll talk about the cabozantinib data. At this ASCO, we're going to see data on ramucirumab in a biomarker selected group, the high AFP group. So, you know, I think we want to try to make decisions on high levels of evidence. But at the same time, while we're waiting for that evidence to filter in, we need to try to get our patients at least to second line to get that option of treatment, which brings us to another point that we touched on earlier. In order to get a patient to second line treatment, we need to get them to front line treatment appropriately. And if patients get caught in that whirlpool of repeated chemoembolization beyond where the data supports its use, and patients start decompensating, so they start having evidence of liver dysfunction, and then send them to the oncologist or hepatologist, whoever manages them with systemic treatment, depending where you live. But if they're getting to systemic treatment late in their disease course, then there's no way they're going to maximize frontline treatment, let alone second-line treatment, and now even third-line treatment. And so I think we need to be aware that systemic treatment for liver cancer is no longer a one-drug pony, right? There's a lot of options that are evolving rapidly, and I think probably if we glean from other diseases that have a lot of choices, patients who get treated sequentially with effective drugs probably do better.